Atrial septal defect. Atrial septal defects are a group of congenital anomalies that comprises those of the communication between the right and left atria, thereby allowing shunting of the blood between the pulmonary and systemic circulation. ASDs are the third most common congenital cardiac defects. Most defects are sporadic with no identifiable cause. There are reports of familial clusters of the secondum defects, most inherited in the autosomal dominant fashion, and the fetal alcohol syndrome. The first trimester cigarette consumption and certain antidepressants have been associated with ASDs. Other maternal factors such as diabetes, advanced maternal age have been linked with increased risk of ASD. Atrial septation involves the septum primum and the septum secundum and the atrioventricular canal septum at 4 weeks of gestation. The septum primum develops covered by the mesenchymal cap. The space between the septum primum and endocardial cushion is called as foramen primum or the ostium primum. The septum primum fuses to the endocardial cushions, then the septum secundum appears to the right of the septum. At the 5th week of gestation, the opening develops within the septum primum called as foramen secundum. At approximately 9 weeks of gestation, the septum is nearly fully formed and the foramina secundi closed by the way of coalescing fenestrations. The foramen ovale remains throughout the pregnancy, allowing the oxygen-rich blood from the ductus venosus to reach the left atrium. Patent foramen ovale, these are not considered as ASD. They can be presented in 30% of otherwise normal heart and are caused by the failure of the septum primum and septum secundum to fuse after birth, leading to a persistence of the natural valve-like opening on the fossa vallis, and this defect may permit intermittent shunting. Secundum defect, this is most common ASD, and it is caused by failure of septum primum to cover the ostium secundum and is found by the fossa ovalis. Secundum defects can be associated with syndromes like Holt-Oram, NKX25 mutation, skeletal abnormalities of hand and arm, and Charcot-Levine, that is short torso, neck due to abnormal rib spine development, Alice-Van curve, short limbs, polydactyly, and abnormal fingernails, Noonan syndrome, facial features, short stature, bleeding problems, rib cage abnormality, and Budd-Chiari syndrome, which is occlusion of hepatic vein, and Down syndrome, that is trisomy 21. Primum defects account for 10% of the ASD. These are due to persistence of ostium primum and can be associated with AV canal defects. Atrioventricular valves are often abnormal as well, and the cleft in the anterior mitral valve. Conduction access is abnormal. The sinus venosus defects accounts for about 4 to 11% of the ASDs, and these ASDs are associated with a partial anomalous venous return and typically found on the posterior rim, and there is a superior and inferior sinus venosus defect. The superior ones have the PAPVR of the upper lobe veins, and the inferior ones have PAPVR of the middle and lower lobe veins. Most commonly, one or both of the right pulmonary vein drains either into the RA or SVC. One of the vein will drain into confluence of SVC and the RA with orifice and the vein forming the lateral part of the defect. The anomalous from pulmonary veins less often will drain on the IVC-RA junction and seen in the Scimitar syndrome. The coronary sinus defects, these accounts for 1 to 2% of the ASD, and coronary sinus is often unroofed either completely or partially. The common atrium, the septum primum and septum secundum, and the atrioventricular canal septum are absent and often in the heterotaxy syndrome, that is situs ambiguous. Most ASDs result from left to right shunting through these defects, and this is mostly a diastolic shunt, and there is more flow across the ASD during the diastole and systole. The direction and magnitude of the flow is determined by both size and defect and compliance of the ventricle. And in the neonate, the magnitude of the shunt is small because of the relatively small ventricular compliance. As the compliance of the ventricle changes with time, the LV becomes less compliant and left-sided pressures increases, and this results in left to right shunting. The increase in the RA volumes eventually results in the RA-RV enlargement with subsequent impaired RV function, and increased pulmonary blood flow results in changes to PVR and subsequent development of the pulmonary hypertension. Up to 50% of the patient with the untreated ASD and develop the pulmonary hypertension to the 40 years of age as the defect becomes more chronic and left untreated. Irreversible changes occur in the pulmonary vascular bed, leading to development of Eisenmenger syndrome and the flow reversal of the shunt. The ASD less than 4 millimeters tend to decrease the size and may regress the first year of life. Those greater than 8 millimeter usually fail to decrease in size and persist or increase in size. In general, 70% of the patient with defects less than 4 millimeter decrease in size, and 12% remain unchanged and 18% increase, while for the defect larger than 8 to 12 millimeters, 9% decrease in size and 15% remain unchanged and 76% change in size. The majority of the patients with ASD are symptomatic, and symptoms tends to occur with pulmonary systemic shunts ratio increase to greater than 2, and QP to QS is greater than 2:1. As the shunt increases, the exercise tolerance decreases, tachyarrhythmias increases, RV dysfunctions occur, and the pulmonary hypertension develops. Repair of the ASD results in a normal life expectancy. Symptoms due to ASD typically manifest with QP-QS exceeds 2:1. Exercise intolerance is uncommon in children, but adults will present with a decreased exercise intolerance, palpitation, dyspnea, and exertion, syncope, and edema. Atrial fibrillation in the adult patient is not uncommon, and the full spectrum of the symptoms associated with congestive heart failure may be evident. Children may present with repeated respiratory illness and infections. However, arrhythmias are uncommon in children, and the presence of advanced pulmonary hypertension leads to cyanosis and decline in the patient's functional status. These patients tend to be older, with the diagnosis occurring around 50 years of age. On examination, the patient is usually acyanotic. The precordium can be hyperdynamic, and there is a wide splitting of the second heart sound with variation of the respiration. The systolic flow murmur heard at the left upper external border and is reflective of the increased flow through the pulmonary valve. An apical mid-diastolic rumble can often be appreciated and is reflective of increased flow through the tricuspid valve. The Campbell reported mortality rate of 0.6 to 0.7% per year in the first 2 decades of life, 4.5% per year with the 4th decade, and 7.5% per year in the 6th decade. Physical exam, the young patient with typically acyanotic with few or no symptoms, hyperdynamic precordium, widely split S2 without the respiratory variation, and the soft systolic murmur over the pulmonary area, and the left upper external border diastolic rumble with the tricuspid area, and the left lower external border. The holosystolic murmur occurs over the apex, indicates the mitral regurgitation that could be due to primum ASD or mitral valve prolapse. The EKG tall P wave due to the right atrial enlargement, a prominent R due to the right ventricular hypertrophy or the right precordial leads can be seen. And this axis deviation, complete or incomplete right bundle branch block, and the atrial tachyarrhythmia such as atrial fibrillation in adult. Left axis deviation with the superior axis could indicate the primum defect. Chest X-ray cardiomegaly and the prominent lung markings. Echocardiography, the diagnosis of the ASD is confirmed throughout the echocardiography, and this modality of choice is appreciating for the anatomic defects and can also facilitate the calculations of the shunt fraction The bubble contrast via the agitated saline injection can help detect the lesion. The injection of the agitated saline in the left arm venous cannula can diagnose a coronary sinus septal defect in presence of the left superior vena cava. MR and CT scan, these modalities are often reserved for more complex defects, especially the anomalous pulmonary venous return, as they are best defined by the complex anatomy and facilitate surgical planning, and quantitative assessment of the flow can also be performed using the MRI. Cardiac catheterization, this is rarely used in the diagnostic modality. However, it is indicated in the settings of the pulmonary hypertension where the right heart catheterization is extremely useful. Presence of hemodynamically significant shunt with associated right heart enlargement with or without symptoms is an indication for ASD closure. Class V level of evidence is B. Other indications include the presence of anomalous pulmonary venous return or the mitral valve cleft with insufficiency. Traditionally, a QP-QS ratio is 1.5:1 with and considered with elective indication of closure. The suspicion of paradoxical embolism in the absence of other causes indication of the closure. The class 2A level of evidence C or vocation that might cause the paradoxical emboli. Less common indication is large ASD in setting of transvenous pacemaker or transvenous AICD. The children elective closure is recommended most commonly between the ages of 2 to 5 and the presence of the fixed pulmonary hypertension PVR of 8 to 12 Wood unit. Despite the vasodilator challenge, the inhaled nitric oxide, oxygen and prostacyclin analogs is a contraindication for surgery, and the presence of other congenital defects that relies on the physiology of the atrial septal defect is also contraindication to closure. Treatment. The surgical repair is usually performed by the median sternotomy with the bicaval cannulation and the cardiopulmonary bypass. Cable snares are used for complete venous isolation, and the defect is approached through the right atriotomy. The defect can be closed either primarily with a patch consisting of material of surgeon's choice. Patches can be constructed through the autologous pericardium, bovine pericardium, or PTFE. Sinus venosus defects are associated with anomalous pulmonary venous return and treated with a patch that serves as a baffle, redirecting the pulmonary blood flow to the LA and thereby closing the defect. Often the defect is located such that the patch closure may compromise the flow of SVC. In such instances, a second patch can be utilized to enlarge the SVC and avert obstruction. Alternatively, especially when the anomalous vein drains higher to the SVC is divided above the anomalous vein and reanastomosed to the right atrial appendage. The anomalous vein is then baffled to the right atrium. Warden's procedure, and the case of unroofed coronary sinus orifice into RA is patched closed onto the roof of the coronary sinus and is reconstructed using a patch that serves as a baffle of redirecting flow to the RA, obliterating the ASD. Complications associated with surgical repair, including the patch dehiscence, heart block, sinus node dysfunction, long-term survival when the ASD are corrected before 25 years old, is indistinguishable for the general population. These defects can safely be closed near 0% mortality, and the sinus node dysfunction can occur up to 55% of the patient with the sinus venosus, ASD, and pulmonary venous return. Other morbidities, including the atrial tachyarrhythmias, thromboembolic events, residual shunts, and care should be taken when addressing the inferior defects in including the eustachian valve patch closure, thereby baffling the IVC to LA, the consequence of which will be cyanosis and destruction after wearing from CBP. By comparison, the pregnant women are unrepaired ASD had an increased risk of preeclampsia, fetal loss, and low birth weight. The outcome of the woman with repaired ASD was similar to general population and pregnancy should be avoided in women with ASD and severe pulmonary hypertension. TRIATRIATUM is a subdivision of the LA into two chambers by a fibromuscular membrane into the common pulmonary venous chamber and the chamber containing the LA appendage and the mitral valve as seen in the diagram, and there is an obstructing membrane which can be seen with a downward arrow in the diagram. The communication between both chambers is limited to one or multiple perforations of the membrane, and there are multiple classification schemes for the entirety based on the anatomy of the fibromuscular membrane and the association communication between the chambers. Clinical manifestations depends on the degree of the pulmonary venous obstruction and whether there is an ASD between the RA and common pulmonary venous chamber, and the signs and symptoms of those pulmonary venous congestions such as poor growth, pulmonary edema, pulmonary infections, pulmonary hypertension, the right-sided heart failure. The pulmonary hypertension is common and the pulmonary vasodilator therapy is dangerous in unpaired patients. Diagnosis is made by echocardiography, although MRI can also be useful, and the treatment is surgical with complete excision of the membrane irrespective of the age. The repair is usually performed through the transseptal approach via the right atriotomy, although a left atriotomy can be used for the older children and adults. TRIATRIATUM dexter, the subdivision of the RA, is much rarer defect with the clinical presentation that varies from asymptomatic to cyanosis from shunting through an ASD to the right-sided heart failure. The treatment is surgical excision of the membrane. Thank you very much. Hope you have enjoyed. If there is any feedback, then please let me know. Thank you.